Good afternoon, and thank you for being with us today. I have the pleasure of introducing Dr. Saulnier, one of the authors of the Vineland, and so I want to tell you just a little bit about her before I turn this over to her to tell you about case studies for neurodevelopmental disorders. Dr. Saulnier is a clinical psychologist by training who specializes in the diagnostic evaluation of autism spectrum and neurodevelopmental disorders. While training at Yale with Drs. Ami Klin, Sarah Sparrow, and Dominic Cicchetti, Dr. Saulnier developed a passion for adaptive functioning and the implications that adaptive behavior has on functional outcome for individuals with disabilities. It was this interest that led her to a close working relationship with Dr. Sparrow on adaptive profiles in autism, and then eventually to working on the revision of the Vineland. Soon after Dr. Sparrow's passing in 2010, Dr. Saulnier began working with Dr. Klin at the Marcus Autism Center and Emory University School of Medicine. Welcome, Dr. Saulnier, and thank you.
Thank you so much for that kind introduction, and welcome to everyone. Thank you for taking the time to attend today's webinar. I did want to say that although I am currently affiliated with the Marcus Autism Center and Emory University School of Medicine, I will be leaving both next month and starting up my own private practice and consulting company. So the next webinar that I do, I'll have a different affiliation. I'm very sad to leave both Marcus and Emory, but I will continue my academic collaborations with Dr. Klin and many of my colleagues moving forward. So I do need to disclose that as a co-author of the Vineland-3 and also co-authors of 2 books within the Essentials series from Wiley, that I receive royalties. And in fact, it was the most recent book that I wrote, The Essentials of Adaptive Behavior Assessments in Neurodevelopmental Disorders, with my colleague Cheryl Clayman, that generated the ideas to do this type of webinar, because Pearson was interested in having something more broadly on neurodevelopmental disorders and thinking, wow, I just finished a book on this very topic. So I'm thrilled to present on it today. So here are your learning objectives, and I first want to start by going through the differentiation between what we consider cognition versus adaptive behavior. So as many of you know, as clinicians in the field, we are defining intellectual disability based on the criteria set forth by the Diagnostic and Statistical Manual, which is now in its 5th edition. So intellectual disability is defined by 3 criteria, first of which is having deficits in cognitive functioning. So in prior DSMs, this was considered an IQ score falling below 70 when 100 is the mean. However, now it is approximately 2 standard deviations or more below the mean, which helps us out in that flexibility as many of us encounter when we're doing these evaluations, that not everybody falls within the clean cutoffs that we have. So we have to have a measure of cognition or IQ where we can generate standard scores. And then in addition to having cognitive delays, we need to identify deficits in adaptive functioning in the areas of communication, daily living, social participation, and independent living. So these would be conducted with standardized measures of adaptive behavior, such as the Vineland, the Adaptive Behavior Assessment System, the ABIS, which is now in its 3rd edition. AAIDD just came out with a new one just in the past month, I believe, called the DABS, the Diagnostic Adaptive Behavior System. So there are many out there. And then on top of those 2 criteria, then we need to have the onset and the developmental period. So again, this is no longer stating that it has to be below the age of 18 years. It's just that onset had to arise within the developmental period. So we set all these criteria. We can now say someone has eligibility for ID. The severity levels in the new DSM-5 are now keyed more into what we would consider adaptive behavior or levels of functional independence, more so than what it used to be just derived by sheer IQ number. So mild, moderate, severe, and profound severities really key in more to how much support an individual needs. So now if we assess cognition, we have someone's repertoire of skills. So cognition, depending on the definition that you are reading, is generally defined as, innate skills and or acquired skills throughout life, capacity, and so this is one's optimal performance. So when we're assessing for cognition, this is why we do it under optimal conditions, one-on-one setting with very few distractors. If anyone's on medication, we want them to be on their medication. We want to get the absolute best performance of an individual so what we know their complete full capacity of skills is. Adaptive behavior, on the other hand, is not the repertoire of skills. It's how someone takes one of those skills and applies it to real life with independence when life demands that behavior. So these are skills that are necessary for personal and social sufficiency. So instead of it being what the person can do, it is what the person actually does do independently, meaning no prompt supports, reminders, or help from anybody when they are just living in their daily life, activities and routines across contexts. So think of the differentiation as cognition is the can-do, adaptive behavior is the does-do. So there are main tenets of adaptive behavior that have been outlined as early as the early 1900s when Edgar Dahl first started using this construct of adaptive behavior, which he actually called social competence or social maturity. So when defining these tenets, first and foremost, adaptive behavior is age-related, meaning that younger children will have a smaller repertoire of adaptive behavior skills than older individuals because as you age, you are increasing your repertoire of these behaviors. Adaptive behavior is defined by the expectations and standards of others because we are immersed and live in a very social world. And then adaptive behavior is defined by the typical performance, not the ability. So again, the does-do, not the can-do. And what's wonderful about adaptive behavior is that it is modifiable. So it changes over time. Adaptive behavior can be changed by intervention or lack thereof. It can be changed by trauma. It can be changed by moving geographical locations. It can be changed by injury. So all of these things allow us to assess for adaptive behavior, implement an intervention, and then see quite quickly if we actually can make improvements in the behavior. And then finally, adaptive behavior is unique in that unlike cognition, where everybody aims to have, average, above average cognition, the appropriate goal for adaptive behavior is adequate, solidly average. You don't want to have above average or superior adaptive skills. And this is because you wouldn't want a 7-year-old, for example, driving a car or wandering about independently in the middle of a city at night. So we want solidly average, but you're always measuring in relation to levels of cognition. So even if someone has a superior IQ, you would still expect that their adaptive skills be adequate. However, if someone has below average IQ, you would expect their adaptive skills to be at least below average. So before I go into profiles across neurodevelopmental disorders, I just want to emphasize that when we are using any standardized measure of adaptive behavior, it is critical to ensure that the person, the respondent, the person with whom you're obtaining the information about the individual with a disability, understands the differentiation between the can-do and the does-do. Because many of us who are parents, if someone asks you, for example, can your child get dressed? If I think about can my children get dressed, I would automatically default to yes, of course they can get dressed. They're 9 and 10 years old. They can dress themselves on their own. However, if someone rephrased that question to me and says, does your 9-year-old get dressed with complete independence, meaning no prompt, supports, reminders, or help, how often does that actually happen? That's a very different answer for me. Then I would have to say, oh, really? No, I constantly have to give reminders. I'm constantly repeating myself, saying, and sometimes I'm even physically prompting the person, my child, to get dressed. So maybe 25% of the time, this is done with complete independence. So those two responses have very different scores on measures of adaptive behavior. So you have to be very careful if you're giving a rating scale, meaning you are handing a booklet of items representing all of these behaviors to a caregiver, a parent, a family member, or an intervention provider or a teacher, that you as the examiner really have to inform what the construct is and explicitly state that you're looking for the does do, not the can do. This is why the interview is the gold standard, because during a clinical interview, when a parent says, oh yeah, my kid can do that, you as the clinician can say, oh, okay, about what percentage of the time does your child do that? And if you get a different answer, then you know you're getting a more accurate representation of their adaptive profile. In typical development, this might not be a big deal, but across many neurodevelopmental disorders where there are significant discrepancies between cognition and adaptive behavior, we need to know that we are assessing for this construct in the accurate and valid way. Okay, so with that said, when we're looking at intellectual disability and profiles across this neurodevelopmental disorder, the adaptive deficits that are actually specified in the DSM-5 are conceptual skills, which are more academically based. So on the Vineland, for example, this would be the communication domain with the subdomains of receptive, expressive, and written. And then so you get your reading, writing. It could have memory. It could have numerical reasoning, problem solving, et cetera, depending on the measure that you're using. Social skills are the second area in the DSM-5, and this is your interpersonal play, leisure skills, conversational skills, relationships, but also coping skills, so emotional regulation, behavioral regulation, and more intricate concepts like empathy and caring and social awareness. And then finally, we have our practical skills. These are what you would call your daily living skills: self-management, personal care, recreational and vocational skills, money management, etc. So notice that the DSM-5 does not have motor skills listed as one of the areas of adaptive deficit. Because of this, you're seeing standardized measures like the Vineland moving away from having motor domains be part of the overall adaptive composite. Okay, so research shows that profiles of adaptive behavior and intellectual disabilities are variable depending on the level of cognitive impairment. When we look at individuals with extremely low levels of cognition, such as severe and profound levels, then adaptive behavior tends to fall on par with cognition or mental age. However, when we're looking with individuals with more mild cognitive delays, so in the mild to moderate areas or even borderline areas of ID, then we can see more variability. And so some studies might show that there are stronger correlations, but others not so much. It really depends on the literature that you're reading. What makes this challenging is that, and we'll get into this in more depth when we're talking about clinical evaluations, that we as the clinicians are making these judgment calls. And so sometimes when someone's cognition is falling just on the border of two standard deviations, whether it's a 73 or a 67, and then adaptive scores, we're getting the same thing, and overall score is just hovering around that standard deviations, we need to make the judgment call of whether or not this is actually intellectual disability. So I think we'll see more research being done as we are seeing the DSM tying cognition more to adaptive behavior rather than just purely level of cognition. So as saying, the challenges in diagnosing borderline to mild ID is that it's based on clinical judgment a lot of the times. A lot of the times it's because of variable profiles. So someone might have strengths that are in the average range, deficits that are in the very impaired range, but your overall averaging out is in that borderline area. And so then we as the clinician have to figure out ways to advocate for these individuals, because if we're using, for example, an adaptive behavior composite or a full scale IQ, that could hurt us in our advocacy. And how can we use verbal IQ versus nonverbal IQ versus specific areas of adaptive delay. Then with intellectual disability, it's very unlikely that ID is just happening in a vacuum. There is so much comorbidity that comes with having intellectual disability. In fact, estimates of comorbid psychopathology are as high as 4 times the general population. And when we look at the milder cognitive impairments, we see more psychopathology and more affective disorders, whereas when we look at more severely cognitively impaired individuals, we might see the medical complications like epilepsy, medical complications associated with genetic disorders like cardiac defects, et cetera. But those more cognitively impaired individuals might be spared in the psychopathology. Depression is one of the most common comorbid psychiatric conditions that you're going to see with the less severe cognitive deficits, with one study showing the cognitive error of underestimation of the ability to cope being most predictive of depressive symptoms. And then deficits in intellectual and adaptive behavior skills increase the risk of these psychopathological disorders, including depression. So the more that you're seeing global deficits across areas, the more you're going to see more psychopathology. So moving on to epilepsy, not everyone with epilepsy has intellectual disability, and certainly not everyone with ID has epilepsy. So epilepsy is defined by having at least 2 or more unprovoked seizures more than 24 hours apart. So these are not febrile seizures, for example. They would have to be more severe than that. And so you will have a seizure disorder as defined by such, but even if you're just having seizures, whether or not you're getting to the level of epilepsy, you're going to see adaptive impairments coming along with that. Certainly the adaptive profiles can vary depending on cognition, everything that we just talked about, where research has shown that adaptive skills can be stronger than expected in those with lower cognition compared to those without cognitive impairment. When we get to autism, we'll see this phenomenon again. So when we think of people with extremely impaired cognition, so severe and profound cognitive deficits, we as clinicians are very inclined to automatically recommend adaptive treatment interventions. So, for example, we need to teach this person how to dress themselves. We need to teach this person how to feed themselves. We need to teach this person how to take a bus. We need to teach this person how to manage, basic money skills. So we automatically are recommending functional daily behaviors. However, with someone with higher cognition, a lot of times we may overlook those very basic adaptive skills and recommend things that might be missing the boat of those building blocks that the individual might not have had to begin with. So without proper assessment of that to identify these loopholes, then we're missing making the recommendations. So we actually see more pronounced adaptive deficits in those with milder cognitive impairment or even without cognitive impairment. Certainly when seizures are associated with a genetic condition, you can see that adaptive skills can decline over time. Depending on the research that you're reading, you have to be careful of whether an apparent decline is actually declines in standard scores versus age equivalent or growth score values, because declines in standard scores, as you know, aren't necessarily indicative of a regression per se. It could just be that the person's making adaptive gains, just not enough to be commensurate with their chronological development. So as the standard scores are going down, they're still actually acquiring new behaviors just at a slower pace. And interestingly, adaptive behavior has also been found to correlate with medication use in epilepsy, in that the more medications a person is using to control their seizures, the lower adaptive scores are found. So here is a case example for an individual with intellectual disabilities. So we'll call this person Johnny, age 13 years, 2 months, assessed by the Wechsler Intelligence Scales for Children, 4th edition. And you'll see that, across the index scores, verbal comprehension, perceptual reasoning, working memory, and processing speed, that all are falling more than 2 standard deviations below the mean with a full scale IQ of 66. When you're looking at the Vineland scores here, you can see that standard scores are falling pretty commensurate with overall IQ, however, still delayed in comparison to chronological age. So by definition, there's adaptive delays, there's cognitive delays, so this person meets criteria for intellectual disability. So to summarize, adaptive scores are delayed but generally on par with cognition. There was a relative strength for this individual in domestic daily living skills. And it's important to note that this individual's adaptive skills in some areas actually fell slightly above what would be expected given his cognitive level, suggesting that he's learning and applying functional and practical skills to his daily routines. So we always like to look for that because that is indicative of optimal outcome when someone's capacity, when someone is actually performing these skills to their capacity. So when we are writing recommendations based on the information we're gathering in an assessment on adaptive behavior, you can literally pluck the items themselves from the standardized measure right into your recommendations because the behaviors that a person is expected to be doing with independence based on their cognitive level and their chronological age, but they're not, then that is a flag for we need to possibly teach this person this behavior. Now, with many individuals, especially those with more impairment, you're going to have no shortage of these behaviors to put in your report. So you can clump them by areas, so, enhanced communication skills, and then all of the things that we would like to see Johnny doing with more independence are those specific behaviors that come right from the items themselves. Then the daily living skills, then the socialization skills. And the more overwhelming these become, the more there is a need, not necessarily for you as the assessor to determine the priority, but it really is you generating the list of behaviors where the person is falling deficient, and let the intervention team, the people working directly with the child, including the parents, including outside providers, everyone look at this list of behaviors, which can be extensive in some cases, and they determine the hierarchy. What should we prioritize? There are 5 adaptive behaviors that Johnny really needs that to be functionally independent across context right now, and everything else is going to go on the back burner until we get these 5 behaviors. And then we can add 5 more. And then we can add 5 more. So you don't want to overwhelm an intervention team, but make an explicit statement in your report saying that his team should prioritize these based on what they feel are the needs of the individual. So now moving on to profiles in Down syndrome. So again, we're going to see an overlap with Down syndrome and intellectual disability. So Down syndrome is prevalent in about 1 to 700 or 1,000 births. It affects both males and females of all ethnic and socioeconomic backgrounds. And when we see Down syndrome, there is hypotonia in many cases, so you're going to see motor deficits that even might be more pronounced than you would predict given their cognitive disability. So we want to assess for that, and a lot of times the adaptive behavior measures are fleshing out these motor vulnerabilities. Intelligence can be variable. Not everybody with Down syndrome has intellectual disability, but many who have ID, their IQs are falling in the moderate range. And then language skills tend to be delayed, but you can see socialization skills actually being stronger or even strongest in individuals with Down syndrome. So looking at adaptive profiles, research shows that greater strengths are in adaptive socialization skills, and many of you have interacted with individuals with Down syndrome. You will see this clinically and anecdotally, that these individuals are very motivated to socially interact, but they might not have the communication skills to effectively navigate those social interactions. The weaknesses really depend on cognitive level. So individuals with Down syndrome who have higher cognition have greatest weaknesses in their communication skills, whereas those with lower cognition can have more weaknesses in the daily living skills. Interestingly, a study found that years in mainstream education actually was related to stronger communication and socialization skills, whereas the daily living skills tended to be predicted by overall cognition. Despite weaknesses, adaptive behavior in Downs tends to be better than expected given cognitive and academic abilities, and this is wonderful prognostic outcomes for individuals who, young adults that will be holding down a job, living independently despite even having cognitive impairments because their functional daily living skills are so strong. In Downs, we see that adaptive skills can increase with age, and compared to individuals with other intellectual disabilities, those with Down syndrome have fewer maladaptive behavior deficits. Now that's to say clear of other comorbidities, because certainly if you have the complexity of Down syndrome, for example, with autism spectrum disorder, with et cetera, you can see more behavioral issues. Okay, so now moving on to profiles of adaptive behavior in autism spectrum disorders. So autism is a neurodevelopmental disorder, likely of genetic origin, where the symptoms are unfolding over the first few years of life and include the hallmark symptoms of impairments in social communication and interaction, and then a host of restricted interest, repetitive behaviors, need for sameness, sensory processing impairments, etc. So autism affects more than 1% of the population. Because of the genetic liability, it's one of the most, if not the most, heritable neurodevelopmental disorder. So if one child has autism, the chances of a family having a subsequent biological child with autism is 1 in 5 rather than 1 in 68. And there is extreme heterogeneity across cognition, across language level, across autism symptomatology, and across behavioral presentations. So this is why we call it a spectrum disorder. No two individuals with autism will look the same. You can have someone who's minimally to nonverbal to someone who's extremely verbal and nonstop talking. You can have someone who has severe or profound intellectual disability to someone who has a superior IQ. So when we look at levels of cognitive functioning, not unlike when we were talking about intellectual disability, when you have autism with intact cognition and intact language, you're more likely to see psychiatric comorbidities like anxiety, depression, suicidality. And then when you have individuals with autism who have significant cognitive impairment, you're more likely to see the medical comorbidities, the seizures, the genetic disorders, and the associated complications that come with those. This is where we hear people using the terminology high-functioning autism and low-functioning autism. What ends up really being more associated with that terminology is level of cognition. When we say high-functioning autism, we're not talking about someone with autism who has mild autism symptomatology. We're talking with someone who has intact cognition, and vice versa. So in fact, without getting into too much detail on autism, when we look at adult outcome and how much of a poor outcome it is in our field, cognition and language alone is not good enough to be associated with good outcome in autism, meaning holding down a job, living independently, having successful social relationships that help you successfully navigate the social world. What ends up being more predictive above and beyond, but you need intact language and cognition, certainly, but above and beyond just that is adaptive behavior. So I would rather look at the spectrum at levels of adaptive functioning rather than levels of cognition, because like I said, most of us are pretty good at identifying the adaptive needs for individuals with lower cognition, dressing, bathing, toileting, feeding, etc. We're not so good at recommending functional independent skills for those with intact cognition and language, because we just assume that if someone has an average, above average, superior IQ, that they have all these basic skills, and many, many times they don't. If they do, then we need to teach the more intricate adaptive behaviors that are associated with someone at a higher cognitive level. So historically, in the field of autism, adaptive skills fall significantly below age and IQ. More recently, we are finding out that these discrepancies are really more apparent in individuals with autism who don't have intellectual disability, whereas those who do have cognitive impairments, just like in ID, you're seeing adaptive skills fall on par with mental age or even above mental age. But with individuals with autism who have average or above average IQ, we're seeing significant discrepancies, often 2 to 3 standard deviations of adaptive behavior falling below IQ, especially in the area of functional socialization skills. So to illustrate this, there are just 2 studies that have been done looking at quote-unquote high-functioning or cognitively able individuals with autism. Here the dotted line is IQ, so these boys ages 8 to 18 had solidly average cognition, and here are their adaptive scores on the Vineland. So red is communication, green is socialization, blue is daily living skills, and pink is the overall adaptive behavior composite. This discrepancy here was more than 3 standard deviations between cognition and functional socialization skills. We replicated this with a sample from the University of Michigan and found the same pattern. If we split this sample in half, the older individuals had a larger gap between cognition and adaptive behavior than the younger individuals. We can't say necessarily that this is a longitudinal effect because it's a cohort sample, meaning that does that gap widen with age? Longitudinal studies have fleshed that out more. But we replicated this in a much larger sample, showing that despite the fact that cognition was equal, not significantly different, between a younger age group versus a lower age group, that the younger kids in blue here all had significantly higher adaptive skills than the older individuals. This could be a treatment effect. Neither of these studies were focused on treatment, so it could be that more recent intervention has started to focus better on adaptive behavior, whereas 10, 20 years ago, those older individuals didn't have the benefit of that intervention. But I can only say that anecdotally and not based on research. Okay, so here is an example of this using the now outdated Vineland-2. But if you looked at a profile here of autism, what you tend to see is within the communication domain, this is illustrated in the figure just beforehand, you're going to see deficits in receptive and expressive language, but an overall strength in written. We see the strength in written in autism because people with autism are driven to anything concrete that doesn't change, things that always stay the same, like numbers, letters, reading, and writing. So you'll always see a relative strength in written, which will inflate an overall communication domain, which is why you saw that red bar in the previous figure be the highest. If you actually control for that, receptive and expressive deficits are often as low as socialization deficits. Daily living skills really depends on the individual and the family with whom they're living. As you can imagine, with any disability, parents have their priorities of what they need to focus on, and dressing their kid, feeding their kid, all that kind of stuff. If them helping and assisting in those types of activities is easier for them on life, then they tend to do it because they're focused on the actual impairments that their child has, like communication, speech, motor impairments, etc. Socialization in autism, you're going to see the overall lowest adaptive score, certainly in interpersonal relationships and often in coping skills, because coping skills, the behaviors listed in the items there are behavioral regulation. Just be careful about play and leisure for autism because it's play and leisure. So the leisure items will actually be areas of strength in autism, engaging in activities by oneself, whereas the more interactive play skills will be the areas of deficit. So here's a case example of a girl aged 9 years, 0 months, and she has overall average to below average IQ scores. So you can see here there's variability, and when that is the norm, not the exception in autism. Processing speed is often the lowest area on Wechsler standardized tests, not because individuals with autism are necessarily struggling with processing speed. It's because the subtests on these standardized measures are often timed tasks, and people with autism struggle with the concept of time. It's very abstract. So they're not going to attend to the time concepts, but they'll be accurate in their performance of the actual tasks. So you need to qualitatively look for that in things like coding and symbol search and cancellation subtests to see that differentiation. So you can see here that despite having average to below average scores, that you're seeing adaptive deficits above and beyond, which is why, especially in the area of socialization. This is why in autism, an assessment of adaptive behavior becomes standard practice, best practice as part of a comprehensive evaluation, because it's often diagnostic. You're trying to flesh out whether the social deficit is above and beyond what you would see based on the person's cognition level. So the adaptive in comparison to cognition is often helpful in that diagnostic call. So for this particular case, overall adaptive skills are significantly delayed in all areas. They're variable scores, so anytime with cognition or adaptive behavior that you see variability across domain or subtest scores, then certainly interpret the overall composite scores with caution. And then we're looking to see if this individual's adaptive scores fall below what would be expected given both her age and cognition, and they were, suggesting that she's having difficulty independently applying her repertoire skills to daily contexts and routines with independence. And then understandably, given that autism is social disability, that her socialization skills are her area of significant deficit. And then again, you are going to generate a list of specific adaptive skills based on the items for which the person doesn't receive full credit. So focus on the zeros, which is, rarely or never performs the behavior with independence, and make a hierarchy. So you're going to have daily living skills deficits in this example, safety awareness. Safety should always go to the top of the hierarchy, and then coping skills, which would be behavioral regulation. So oftentimes in neurodevelopmental disorders, the most pressing behaviors that need to be addressed in intervention have nothing to do with the diagnostic criteria for the neurodevelopmental disorder. It can be the behaviors that are associated with the disability that become so strikingly critical to treat. So safety always is an example here, whether it's pica, eating inedible objects, whether it's darting, what we call elopement, taking off from a caregiver or person. So you're either wandering in the middle of the night, or you're jumping out of moving cars, or running into a street of oncoming traffic. It could be self-injury. It could be aggression. So any of these affiliated behaviors need to be prioritized within an intervention program. Okay, I know we're moving quickly across. There are just too many neurodevelopmental disorders to cover even in this 1-hour webinar, but this is just providing an overview. So now moving on to attention deficit hyperactivity disorder. This obviously is characterized by inattention, disorganization, and/or hyperactivity and impulsive behaviors. ADHD is highly prevalent in the U.S. With a national average of 11%. Children and adolescents with ADHD can show significant impairment across areas, so IQ, social impairments, and practical adaptive behavior skills. And social deficits can be significant sequelae to having ADHD. So it's not uncommon that individuals who suffer from ADHD are referred for evaluations for autism spectrum disorder just because the social impairments are so significant. The difference is these impairments in ADHD are the byproduct of having ADHD. They're not the driving force of the disorder, in which autism they are. It's the core disability. So profiles of adaptive behavior in ADHD that certainly when you have someone who has fleeting attention, they're moving all over the place, they're hyperactive and impulsive, they're not listening to multi-step instructions, you're going to see lower adaptive receptive communication skills, because on many measures of adaptive behavior, including the Vineland, your multi-step instructions are falling under the subdomain of receptive communication. So ADHD is going to impact or affect those areas. And certainly when you are not following instructions like this, that can also affect your daily living skills, such as, go upstairs and get dressed and brush your teeth. So it's going to impact personal and domestic care. It's going to impact ability to complete household chores, following instructions, etc. So that's just in the home, certainly in the school context as well. Adaptive skills in ADHD tend to fall below cognition, and just like in autism, this gap has been found to be larger in older versus younger individuals. Maladaptive behavior scores will be higher for both externalizing and internalizing behaviors. And as you know, ADHD is comorbid with a host of other disabilities such as learning disabilities, language disorders, conduct disorder, and oppositional defiant disorder. And the more behavioral disruptive disorders, chronic disorder and ODD, can certainly exacerbate this behavioral presentation. So you're always taking a multifaceted approach to this evaluation. So in this particular case, I'm sorry that you're not seeing some of the text there, but this is an actual, these case examples, which are extracted from the book that I just wrote, are true clinical examples with any identifying information change. So this particular girl with ADHD had superior verbal reasoning skills. So as you can see, her verbal IQ was 147 on the differential ability scale, second edition. She was not even 7 years old. Her nonverbal reasoning was also above average, but not as strong as her verbal reasoning. But then her spatial reasoning was solidly average and significantly lower than her verbal and nonverbal skills, with an overall general conceptual ability or full scale IQ of 134, which we would completely throw out in a case like this because of her variable scores. So what you don't see here is this is her Connors. The Connors scale, the ratings both by the parent and teacher. And so what I just want to explain here, because you're not privy to the entire report, is that her scores are showing as highly elevated on the parent measure of the Connors only, and that she's actually showing within the normal range on most areas by teachers. And this is because she did have lots of structure and support within her school environment because of her ADHD, which is why you'll see this discrepancy. So it's all